Okay, so welcome back, everybody who's still glued to their computer screens. And after a lunch break, if you're in the same time zone, I'm in the Netherlands, which is Central European time zone. My name is Eric Vermetten, and I have the opportunity to moderate this Block 3 session, which is it's a wonderful session with 3 presenters that you will be able to see in your Wova app. I'm pretty sure, and the first that I'll introduce in a minute, and then Matthew up because he's at a different time zone, and we have Michael Midhofer, who's at the same time zone as Matthew Johnson, and I'll give the floor to Ben Sessa with great pleasure from Bristol, the UK. And Ben has exciting novel data that who doesn't know Ben Sessa? He's a psychiatrist, has a legacy in this psychedelic domain for years. He's been working with David Nutt, who moved to Imperial, to London, and Ben is still in Bristol. And Ben he'll take it away, and he's going to give us the title, because I didn't have a title of your lecture on the Wova app. It doesn't really matter, Ben. The floor is yours.
Thank you very much. Hello, everybody. Let me share my screen with you like this. Can you see the, is that working?
Not yet.
Can you see the presentation?
Not yet, Ben.
Oh, not yet. Okay, hang on. Share screen.
There's something going. Yep.
Perfect.
Okay. And there we go. Okay, so this is, I'm going to be talking about the BEMA study, which is the world's first addiction study with MDMA-assisted psychotherapy. So we got this opportunity through a large grant to do a MDMA study, and I was very keen to depart from PTSD, which MAPS thoroughly have nailed down. So I wanted to do something completely different. I was working as an addiction psychiatrist at the time, and so we decided to go for alcoholism. And oh, there we go. So what's driven me very much as a child and adolescent psychiatrist, I'm very much driven by this developmental approach to adult mental disorder and addictions. And people with addictions and most chronic anxiety-based disorders usually have these multiple risk factors. The rates of trauma in childhood are very high amongst people in addictions. And we talk about big T and small t trauma. And I always say, don't take your eye off the ball on small t trauma, like neglect and emotional abuse. It's not just physical and sexual abuse that are considered extremely damaging forms of child abuse. And plus also, as we all know, those of us in mental health, our patients tend to have all these multiple risk factors, including all the psychosocial issues and unemployment and racism and exclusion and poor housing and poor education and transgenerational problems. So we work with these people on the bottom rung of the ladder, and these are very predominant in addictions as well, as we know. We know that addictions are very much driven by impulse behaviors. But we also know that trauma itself has a considerable physical effect on brain development. The amygdala there, the red part, is this part of the brain that responds to fear and a stimuli in the environment that could be risky or dangerous. And we know that children that grow up in an environment in which they are continually exposed to trauma, where everything is fearful, they actually have a physical growth in their brain in which the amygdala becomes hyperreactive. And that green area there is the prefrontal cortex. Now, the amygdala, the red area, is a very old, primitive part of the brain. All mammals have this, from shrews to elephants to humans. And it's very instinctive, what we call kind of bottom-up approach. There's no significant cognitive aspect to it. It's a knee-jerk reaction. But the green area there, the prefrontal cortex, that's the seat of the human part of our brains, where we use all our sophisticated tools like reasoning and judgment and planning and executive functioning. And that can overcome the physical effect of the trauma, the physical effect of the amygdala response, sorry. But in children who grow up with this continually powerful negative stimuli environment, you actually have this hyperreactive effect in the amygdala. They find things more frightening than others. And the prefrontal cortex is stunted in its growth and development. They're not so good at seeing the good in things. They're not so good at feeling good about themselves. They're not so good at trusting people. And in some ways, PTSD is actually a sign of a healthy brain, isn't it? It's almost a positive neurodevelopmental response. It wouldn't be good for the child to always open their arms to this caregiver if they know they're going to get a clout every time they come in the door. So they learn to dive behind the sofa and avoid trauma and pain. But the result is they grow into adults with this cluster of symptoms that are based around trauma, and in particular, alcohol. And it's very much about this concept of attachment. And if you're lucky enough to have a secure attachment, then you have this self-narrative of being a good, achievable person, and this world narrative that people can be trusted. But if you haven't had that, if you've had an insecure attachment, then people grow up with these very rigid narratives of self and world. I'm useless, I'm a failure, I'm unlovable, it's my fault, trust no one. And when you're faced with this kind of identity formation, it's so overwhelming. The best option people can come up with is just to block themselves out with these sedating substances, dangerous substances like heroin, and far more dangerous substances like alcohol, which is why we see these as the two major drugs of misuse in patients self-medicating for trauma-based disorder. So we chose alcohol because it's a huge social and domestic problem. Massive amount of money goes on treating alcohol-based disorders. A quarter of adults in the UK consume over 14 units of alcohol a week, and significant and increasing numbers of people dependent. And I think what's important about alcoholism is we are very poor at managing it. So with the very best that modern medicine can throw at you, with MAP groups, AA, disulfiram, acamprosate, all of the anti-craving drugs, individual therapy, group therapy, rehab, residential settings, the very best modern psychiatry can throw at the alcoholic, we're looking at around 80 to 90% of people are back to relapse within 4 years of completing treatment. This is rubbish. This is a terrible outcome. We were doing better at treating alcoholism in the Victorian times than we are today. So what we did is, before we did the MDMA study, we did a brief observational study. We looked at this cluster of people drinking between 50 and 350 units of alcohol a week. They all underwent a detox, came down to 0. And then without any intervention, we just followed them up over the next 9 months and looked at their rates of relapse. So they were doing all the normal things. They were doing AA, rehab, anti-craving drugs, groups, psychotherapy, MAP groups, etc. And we just saw how well are we doing in Bristol at the moment at treating alcoholism. And if you look at that, there's the line of best fit through that graph. So pretty much back to where they were before they went into detox. So that was an observational study, the outcome study. Now, we know that MDMA works with trauma. And as I said, the work with PTSD is very well established. But we didn't know whether it was going to work with alcoholism. Most of the work with addictions has been done with classic psychedelics, so LSD, psilocybin, or perhaps ketamine in more recent years as well. And going back to the 50s, most of the work with LSD psychotherapy was alcohol. So we know that the classic psychedelics work to treat addictions, and they seem to work by having this mind-blowing mystical peak experience, which isn't so predominant with MDMA. So we didn't know whether it would work, but we do know that MDMA works with the trauma and the empathy aspect. And so we thought, well, there's a lot of trauma associated with alcoholism, so we put 2 and 2 together and we came up with the BEMA study. Very briefly, how does MDMA work? Well, most people often say raises serotonin. It's a bit more sophisticated than that. We've got an increased effect at the 1A and 1B receptors, which is reduction in anxiety and depression, improved self-confidence, that kind of thing. Mild effect at the 2A receptors, where the classic psychedelics work, but also this bizarre kind of paradoxical effect of both the amphetamine part of the molecule creating a stimulation, which through dopamine and noradrenaline, and at the same time, this paradoxical relaxation through the alpha-1 and 2 receptors. So it puts the patient into this optimal arousal zone. And then, of course, there's this hormonal effect at the hypothalamus with the oxytocin, which we all know is the love hormone, if you like. So you add up all these things together, and what MDMA seems to do so well is it takes out the fear response, but the other faculties are intact. You can still think and remember and debate and reflect and do psychotherapy, basically, but the fear is turned off, and that's what makes it quite unique pharmacologically. And there's our traumatized brain, an adult who's undergone trauma as a child and has this hyper-reflective amygdala response and this shrunken prefrontal response. And an imaging study done at Imperial in 2012 showed that MDMA reverses this situation completely, shrinks the amygdala response, turns off the pain, and boosts the prefrontal response, gives you a capacity to see the good in yourself and see the good in others for this brief 6-hour window. So there's our team. Professor Nutt was the CI. I was the PI. There's Michael, who came over and assisted us. And there's Laurie and others at the, Laurie's co-therapist, who were assisting on our study here in Bristol. It was an open label safety and tolerability study, which might make you think, well, that's rather methodologically unsound, no control group, no placebo, but you have to do this kind of study when you're using a new drug in a new condition for the first time. So it was open label. 2 sessions of MDMA in a 8-week course of therapy, sandwiched between non-therapy sessions, like many different psychedelic protocols. The bits either side of the 8 weeks were the same as the outcome study. We took people at pre-detox, they underwent an alcohol detox, came down to 0 alcohol, then they went into the 8-week MDMA study with their 2 sessions of MDMA, and then we followed them up at 3, 6, and 9 months for outcome data. The MDMA sessions themselves were very typical sort of MAPS, manualized type MDMA sessions, very, very client-led, very much about encouraging the patient to be with the experience and to be inside, if you like, and allow the drug to do the work. And we expected to be doing a lot of work around index trauma, but actually what we found was people did tend to have these peak experiences. They did tend to talk about this mystical mind-blowing effect, which was quite a surprise to us, but it was very welcoming to see that. So we took patients, in terms of the demographics of the patients, they were all heavy daily dependent drinkers, all requiring a physical detox. Unfortunately, very undiverse, which was just basically a feature of Western Supermare where we recruited from. But you can see there just the massive impact that alcohol had been on their lives. And all of them had been through multiple detoxes in the past. Now I love this table because it's so spectacularly boring. It says nothing, but that's perfect. That's exactly what we wanted. As a safety and tolerability table study, these are exactly the results you want. Totally tolerated, no adverse events, no deaths, no suicides, no self-harm, no abnormal bloods, no abnormal ECGs. Everyone gave a positive response. So everyone had normal physiological changes during the sessions. So yeah, spectacularly boring, but excellent in a safety and tolerability study. As per guidelines by the risk-averse ethics committee, we meticulously measured all of their physiological parameters throughout the 8-hour session. And pretty typical there, you get this kind of takeoff, cruise, and then landing effect in terms of BP, temperature, and pulse. Drug effects in green there, and anxiety in brown over the course of the session. So that was all, again, spectacularly unspectacular, which is just what we wanted. People often ask, what about this come down effect? What about Black Monday, Blue Tuesday, or whatever ravers are calling it these days? We did not see this. We did not see this. This is the POMS scale. We measured POMS, profile of mood states, daily for a week after each session. The black line there is session 1, and the session 2 is the blue line, and these are pooled scores. Now, in this POMS score, any positive numbers above 0 are depression. Anything below 0 is not only not depressed, but it's actually positive mood. So what we see here is, far from there being come down effects or post-MDMA affect drops in the days afters, people are actually left in a positive afterglow effect, a bit like classic psychedelics. So really interesting. It really blows out of the water this idea that MDMA causes depression or come downs. We just didn't get come downs. They all felt great. MDMA is an incredibly safe drug. And I think one thing that this tells us, that kind of data, is whenever we talk about clinical MDMA, let's never use the E word, because this is not ecstasy. It couldn't be more different if it tried. It's a very safe drug. I'll fly through that, but obviously we had reductions in depression and anxiety. Now here's the pooled data of our 14 patients in the BEMA study. As you can see, as before, they all came in with high levels of drinking, between 50 and 350 units a week, all came down to 0 at detox. And then we followed them up over the course of the 9 months after their 8-week MDMA course. And there's the line. There's the line for the BEMA study. This is the patients that got the MDMA. Now, just to remind you, there's the line of the outcome study. So that's BEMA, that's outcomes, and there they are together. So this is what I call the money shot. Now that, I call this a Mithofer type result. That's a staggering result. I mean, let's not forget this is an open label study. So they weren't randomized, they were different groups. But the point is, the group that went through and had 8 weeks of MDMA-assisted psychotherapy, only 18.7 average alcohol units a week, 18.7 compared to 144.5 without MDMA. The difference between those is staggering and fantastic, and we're incredibly proud of this data. It's open label. We need to do a randomized control study to verify this, but it certainly opens the door to there could be novel treatments and innovative ways of looking at treating alcohol use disorder. Because let's face it, it's a huge public health problem, a massive personal burden, massive financial burden, and it's poorly treated. And what this says to me is, in psychedelic research, what I'm really keen on doing moving forward is picking what I consider the low-hanging fruit, you know, the big public health concerns that deserve our attention and that have poor outcomes currently. So we got a bit of qualitative reports there. Loads of people, they all tolerated it. They all found it very positive and beneficial, which was, you know, exactly what we wanted at this stage. That's our team. And I think an important thing about those of you who are interested in psychedelic research is not some crazy left field thing that only sort of beardos from Western California do. Psychedelic research is now at the cutting edge of neuroscience. And it's all of these publications, all of these institutions are now running psychedelic research programs. So if you're interested in this field, get involved. I remember my tutor saying to me when I was in Oxford and I first started this back 20 years ago, 15 years ago, he said, you know, why are you doing this crazy hippie stuff? Why don't you study something nice and wholesome like SSRIs? He couldn't have been more wrong. And if you have tutors or colleagues that say that, then you just have to say, open and read your journals, because not a month goes by that we don't see this work reflected in high impact peer-reviewed journals throughout the world. It is where psychiatry is going. And it's this beautiful tying in of pharmacology and psychotherapy that makes it so inspiring. And it sounds very grandiose, but I think through psychedelic research and psychedelic clinical work, we're going to rewrite the whole way we do psychiatry. We're going to move away from categorical diagnoses. We're going to move towards patient-driven care plans with bespoke treatments, driven by the patients themselves, driven by their needs, not driven by categorical diagnoses and, let's face it, terrible pharmacology that we have in terms of maintenance therapies that don't get people any better. So, as I said, in terms of the future, I'm really keen to expand MDMA beyond PTSD. It clearly is very well suited to post-traumatic stress disorder because of this unique ability to turn off the amygdala for 6 precious hours. And I think it's, in some ways, it's not that magical. You know, we know there's a 50% treatment resistance in PTSD. And that's really because 50% of people do respond to SSRIs and trauma-focused therapies of various different kinds, but the significant 50% don't, because they're just so overwhelmed by even thinking about the thought of thinking about doing that work. They flee, they go back to the vodka. But with this drug on board that turns off the amygdala for those few brief hours, you can do the psychotherapy and it lasts. They've done that work. And given that trauma underlies most chronic mental disorders and especially addictions, we're going to see an expansion there. So just in the final minutes, I've now set up and run this company, Awaken Life Sciences, and we're opening the UK and certainly Europe's, if not the world's first psychedelic medical clinic. I think it probably is the world's first clinic that's going to actually hang the word psychedelic medical clinic above the door. We have 3 platforms on which we're working here with psychedelic clinics offering initially ketamine, because that's all we've got. but really looking forward to adding MDMA and psilocybin as soon as they become approved. We're also going to be doing training of psychedelic therapists, because there's going to be this huge bottleneck when these drugs become licensed in the next few years. At the moment, you can only really train as a MDMA or psilocybin therapist if you're doing studies in those, which means we're going to have a huge backlog of, suddenly the drugs are going to be available, but no one to deliver them. So we're going to train therapists. And the other thing we're going to be doing is setting ourselves up as a small independent research trials unit, carrying out psychedelic research. And as I said, the kind of research that we're interested in is small, first time, open label, new condition studies, big things. So for example, there's two studies at the moment, several studies at the moment looking at anorexia nervosa with psilocybin. Great idea, anorexia nervosa, important illness, very difficult to treat, poor outcomes. But let's face it, how many people have anorexia nervosa? It's a tiny proportion. I'm much more interested in psychedelic study with obesity. You know, we have 30% prevalence obesity in the UK. So this is where we want to be looking at with our psychedelic research going forward. Big public health problems, first time novel approaches using psychedelics. And I think I will probably stop there. Thank you very much for your attention, and do forgive me for being so quick.
Much appreciated, Ben. If we would have been with you, we would give you a big hand, because this is a great business card, but also wonderful data. And to be honest with you, I've never heard somebody say a Mithoefer type of result. This is something that I will start using. It's wonderful. Let's see if there's a couple of questions. And I may moderate for just a few minutes. Ben, what was the comorbidity of the participants in the study?
So the primary inclusion factor was alcohol use disorder. A lot of people ask this, you know, did they have to have had trauma? Did they have to have had a history of trauma or PTSD? We didn't specify that. We did look at their trauma history later in the study, but the only primary diagnosis we were interested in was, do you have AUD? So that was the primary inclusion factor. But there was quite a wide range. You know, we excluded out psychosis, primary addictions to other drugs other than alcohol. We allowed them to be using cannabis because, you know, this is Bristol. You're not allowed to not use cannabis in Bristol. But yeah, we weaned out psychosis, pregnancy, these kinds of things. And people had high levels of depression and anxiety. We also weaned out serious suicidality and personality disorders. But the primary thing was alcohol addiction.
Okay. Just maybe, if I may, as a moderator, maybe 2 brief questions or so. Ben, it seems as if MDMA has the opportunity to be transdiagnostic. We've seen it now, the results in PTSD and alcohol. You're alluding to another range of disorders. What is your perspective? Is this really transdiagnostic, or where to start or where to end?
Absolutely. You know, the way I'm starting to look and think and feel about psychedelics now, if a condition responds to psychotherapy, it will respond to psychedelic therapy, which basically means every single condition in psychiatry, from personality disorders to schizophrenia to OCD to depression to bipolar, whatever. If we use psychotherapy as a clinical tool, then we can use psychedelic drug-assisted psychotherapy. And whether that's best with ketamine or MDMA or psilocybin, you know, we've got to iron out those things. But I really think we should be thinking transdiagnostically. Or even better, like I said, let's just do away with diagnoses altogether and work towards improving people on a bespoke one-by-one basis.
Thank you. Just breaking a last question. This study's result, I've heard you present at other platforms as well. How are these results received? But please be a little bit brief, but how are they received?
Yeah, I mean, people are really excited by these results. I think people recognize this is an open label study and we need to do a randomized control study with a placebo group. But even if it was just the whole process of MDMA therapy, those results speak for themselves. That group that went through the MDMA treatment were not drinking nearly as much. So that's received with very, very warmly, Eric.
Okay, wonderful, wonderful. Thank you very much. Are you going to stick around, Ben, for the other presenters or so?
No, I'm afraid I've got to take my son for a driving lesson.
All right. It was wonderful that you were with us, and we I think I speak on behalf of the whole ISPPP, which is a sub-conference of the ICPR. Great, and look forward to see. I remember that I walked up to the microphone 4 years ago where you were talking at the ICPR in Haarlem, the Netherlands, and it's been 4 years since. And the world is a different place, Ben. I'm glad to have been able to connect with you.
Great. Well, lovely. Thank you for those kind words.
All
And
right.
thank you for the opportunity to join you all today.
Wonderful to have you.
Good luck with the rest of the conference.
Take care. All right. Bye-bye, Ben.
Bye-bye.
So that leaves me, or brings me actually, to move to the second presenter, who's already thumbnail on my screen, which is wonderful. Last time I saw him was at the ACNP, the American College of Neuropsychopharmacology, where we had a symposium together, Matthew. And that was in early December. Where was it? In Phoenix or Hollywood, Florida or so? At least before Corona.
It was in, Florida.
Florida.
Right.
All right. So we are all aware that you are at the center that has received a ton load of financial support at Johns Hopkins from a series of fundraisers. And with Ronald Griffiths, you've been able to spearhead a series of studies that I think you will guide us through or so, or maybe you have novel things to share with us. But welcome here. It's very early in the morning for you, so glad that you woke up this morning. I assume that you're in Baltimore or nearby.
Right, in Baltimore. So not too early. Yeah.
All right, not too early. So the floor is yours.
About 8:30. Yeah. Well, thank you so much, Eric, and pleasure to see you at least virtually. And I have to tell you, like, this is exciting to be part of this ISPPP and then to continue with the ICPR. Wow, I was really blown away by Ben's data. I hadn't seen, as recent of data as he's just showed in treating alcohol use disorder. So this, like, the field just keeps getting more exciting. And so this has already been an interesting meeting for me, even as a participant. So yeah, I'm going to talk a little bit about everything that you mentioned, Eric. A little bit of the old, a little bit of the new. So if you've seen the old, bear with me. I'll try to just give you a bird's eye view of it, but then move on to some new data. So let me go ahead and transition to sharing my screen. And okay, I think I'm sharing my screen. You should see a title screen, Psychedelics as Behavior Change. Eric, please wave me down if you're not
it's perfect.
seeing that. Okay, wonderful. So yeah, first, just by way of disclosures, I am advising a number of companies that are doing work in this area of psychedelic medication development. So I'm showing you all of those on the screen. And as Eric mentioned, we are now a nominal center. So to be clear, we've been conducting research for almost a couple of decades now. I've been part of the Johns Hopkins group since the early days, and when I joined in 2004. And so we've been plowing away throughout this entire time, but we've just sort of, we've been able to get enough funding for the university to allow us to use the name center, which to many universities means you have to pull in enough funding. So what that means is we're able to really devote a larger portion of the time of us faculty towards this research, because we all have a variety of things we do, and we've been able to transition more fully into the psychedelic area and support ourselves through that research. Because at a place like Hopkins, you have to pull in the research funding to essentially pay for your own position. So thankfully, psychedelics are able to more fully do that. Very much thanks to the center funding. And I won't go through all of the studies. This actually comes with a number of studies that we are going to be doing, and we very much have the pandemic is obviously tragic and unfortunate. The timing, though, has come at a nothing is optimal, but I have to say, when you get funding, it's going to take 6 months to a year, depending on the study, to jump through all of the regulatory approvals and get things started. So we've very much been in that mode, writing the protocols, getting them submitted to the IRB or the ethics board, getting them submitted to our FDA. So a number of these studies that I'm showing you on the screen were well underway in terms of tackling that red tape in order to be able to conduct those studies. So stay tuned for those studies. And a couple of them were already, in fact, collecting data for them. I'm showing you the anorexia study as well as the mood issues in early stage Alzheimer's patients. I never want to give any talk without just at least briefly mentioning that these are powerful tools, these psychedelic agents, including psilocybin. Any powerful tool is going to come with ups and downs, very much contingent on the way it's used. We know a lot about the relevant risks of using compounds like psilocybin. The important thing is for every one of them, we have squarely addressed them, and there are reliable mitigation strategies that result in a very favorable risk-benefit ratio in both a clinical research context, and we strongly believe in future approved clinical use of these compounds. So very much depends on how they are used. So one of my earliest contributions in the area was a 2008 paper which outlined our recommendations for what you should do to connect this research safely, at least with the classic psychedelics, which are a little different than MDMA, but all of these tools have their own risks and require their own mitigation strategies. So we take that very seriously. Extremely briefly, some might be familiar with our earliest couple of studies in healthy normals, or people without a diagnosis to treat. Of course, all of us are humans and have our own issues, which often come to the fore with a psychedelic session, whether you like it or not. But nonetheless, these were healthy normal studies. And one of the most remarkable things in the context of the theme I'm presenting to you, psychedelics as behavior change, is the fact that we saw claims of improvement in mood and quality of life over a year after sessions, after these psilocybin sessions in this randomized controlled research, which was quite remarkable. And because they didn't have a common nominal disorder to treat, everyone came in with different issues, just like we all have our different issues. So it was rather idiosyncratic for the individuals, but people and their spouses and their coworkers and friends, which we also formally assessed, were saying things like, yes, their temper is better. They're more easygoing. They're delving into, they're not dealing with the problems of bad habits of one form or another so much. So these various improvements in behavior over a year later. We followed up the very first study with healthy normals with the second study. That first study used one high dose of psilocybin. The second study really digging into the pharmacology, looking at a placebo plus 4 different active doses ranging from 5 to 30 milligrams, adjusted for body weight, but those are the approximate doses. And the important take home here is that although clearly there's a role of context or set and setting, it's not just these compounds like psilocybin, but it's psilocybin in a particular context, a highly supported context where the person can introspect and go within. That's what results in these. Nonetheless, it's not just the set and setting. There's a very real role of pharmacology that you see under double-blind conditions compared to placebo, and where you see graded dose effects. So larger doses having more of an effect than smaller doses. So one of the take-homes is that increasing the psilocybin dose under double-blind conditions has an orderly effect on mystical experience. I'll explain what that means in a bit. Challenging experiences, or what people can call a bad trip, although they're not necessarily bad in a safe context, and long-term positive attribution. So these claims of improved quality of life and behavior long after the session. And so here I'm just showing you one of these atypical pharmacological outcomes that we've looked at. This rating, this assessment of whether the person considers this experience about a month later, whether they consider it amongst one of the top spiritual experiences, the top 5 spiritual experiences in their life. And you could see a beautifully graded dose-related effect. So clearly there's some pharmacology going on in addition to the set and setting. I mentioned mystical experience. One of the take-homes across those first 2 studies is about 60%, more than half of the participants in both those 2 initial studies met criteria for a so-called complete mystical experience. So the cutoff for complete versus incomplete is admittedly arbitrary, but it's a useful statistical metric. What I mean by complete is satisfying criteria based on these subjective effect scales of where the person endorses a substantial content related to each of one of these areas. So having a sense of unity. So for example, they felt one with the universe, or they felt that all of creation was part of one thing that they were part of. A noetic quality, or the sense of gnosis, this idea that it was a self-validating type of experience as real or more real than everyday sort of normal waking reality, a sense of sacredness, of profundity. You could call this awe as well. A sense of transcending the domains of time and space, almost like those dimensions have less meaning than they normally have. So a sense of timelessness, like the ever-present now, for example. An overriding positive mood to the experience. This sense of ineffability, or the idea that the experience is ultimately beyond words. You can do your best to describe it, but you can only go so far. And sometimes I joke that even though the experience is supposed to be ineffable, we as researchers try to F it up by nonetheless describing it. So if you get my humor, excuse my acronym for a 4-letter word. And I should mention, of course, as I showed you on the last screen, that this construct, it might sound a little woo-woo, but it's not. It's a validated psychological construct. And it goes back to William James, the founder of American psychology over 100 years ago. And he was fascinated, not initially instigated by psychedelic drugs, but although he had some interest there, but the broader idea that throughout the centuries, throughout different parts of the globe, there are all of these written accounts of these extraordinary human experiences, often from a religious but not always a religious perspective, that have remarkable similarities, having all of those dimensions. And so there's this very fascinating history in this research. Maybe one of the most famous examples is Walter Pahnke's Good Friday study, where he applied these to high-dose psilocybin and essentially found, like ourselves and others since then, that with a high dose of a classic psychedelic, that you have experiences that, by their description, by any measure that you can apply, they appear indistinguishable from these so-called, mystical experiences that occur outside of psychedelic drug use. And we've also, as part of both our laboratory and survey work, as I'm showing you here on the screen, have developed the first psychometrically validated measure that can actually assess mystical experience, specifically designed for an acute experience. So the previous measures in this area, which we had used, were designed more to assess one's experiences, the accumulation of experiences across a lifetime. So now we have a scale that's specifically designed to assess mystical experience, say like next Tuesday. And so not just, for the use of psychedelic drugs, which you could schedule for the administration on, for example, next Tuesday, but for any other thing. So for example, meditation or other methods for inducing so-called altered states of consciousness. Across those two first two healthy normal studies, one of the things that we found through increased statistical power through combining those two studies was that psilocybin had a statistically significant effect in increasing personality trait of openness. Now, what is openness? This refers to the trait of having a broad tolerance to the points of views of others, the ability to hold more of a both and perspective rather than an either or, black and white perspective, and an increased appreciation for aesthetics, so art, music and other forms of art. So those characteristics were increased by psilocybin long term. This is interesting because the definition of personality is that it is persisting. It's not something that changes on a day-to-day basis. So, to our knowledge, and we've been saying this for a long time and no one's ever corrected us with an example from the research, this is the first demonstration of a relatively discrete laboratory intervention that has changed a personality construct. So that's really big. And since others have provided evidence that this is held up with other psychedelics in research. So something very special about psychedelics and their ability to alter personality. And we found in relation to this mystical experience, it wasn't just getting psilocybin. There are plenty of folks that had a high dose of psilocybin and they had a strong experience, but they didn't meet those criteria for a full mystical experience. And as you could see in the figure I'm showing you, those people showed on average no change in personality openness. So this is the first out of several pieces of evidence I'm going to show you suggesting that it's not just getting psilocybin. It's not, which suggests it's not just having some effect at the serotonin 2A receptor. It is something about the experience, which nonetheless has a biology behind it. I don't see it as psychology versus biology. I think those are two sides of the same coin. But nonetheless, at this point, I think the most resolution we can provide is at the psychological level. And it really appears that it's not just getting psilocybin, it's the type of experience that one has on psilocybin that is most related to long-term outcomes. So now I'll jump into one of the two therapeutic studies that I'll focus on. This is the cancer study. So treating people with cancer-related distress, so Strong's depression or anxiety symptoms. 51 patients in our study all had life-threatening cancer of a variety of types. About a third had some type of DSM disorder related to depression. About a third had one of the anxiety disorders, and about a third had a combination of both. It was a within subject crossover design, meaning everyone had both a high dose of psilocybin, which we meant to be the real intervention, if you will, and a trivial dose, which was essentially designed to serve as a placebo, more for the instructional set, so that we could tell everyone on every session, you're going to receive psilocybin. A substantial dose is going to be given on at least one of those sessions, although it could be given both. So we kind of kept people on their toes in terms of expectancy. But everyone had each of that high dose and the comparison trivial dose. They were randomized to have it either the high first or trivial second, or vice versa. After each one of those sessions, we had a 5-week follow-up when we assessed those depression and anxiety symptoms, and then we crossed the person over to whichever condition they didn't receive before, and then another 5-week follow-up, and then we assessed everyone 6 months. And so here we collected many outcomes, but I'm showing you one of our gold standard measures, the Hamilton Anxiety and Depression Scales. Depression on the left, the two groups shown in the different colors. At baseline, that's before randomization. So as you would expect, people are coming in at around the same level in each of those two groups. And you'll have to trust me, these are clinically severe levels. This is absolutely indicative of clinical distress and a diagnosable issue. Post one is 5 weeks after that first psilocybin session, and people are coming in in the high dose group with substantially reduced symptoms in the range on average of not having a diagnosable disorder anymore. These people are squarely in the normal range on average. Also a substantial reduction in the trivial dose group, probably because of both the rapport building and the so-called placebo effect. Nonetheless, not nearly as large as the reduction in the high dose group. So again, pharmacology is doing something. Post 2 is 5 weeks after that second session. Now everyone's had the real deal, whether it's 5 or 10 weeks ago. And now everyone on average in both groups is down to that extremely low level of symptoms. And then remarkably, that's relatively unchanged at 6 months. And the same essential story unfolds for anxiety and depression. So that's remarkable, especially in the context where an intervention like ketamine for depression is legitimately considered a breakthrough for having antidepressant effects that last about 1 week. That's great. We need all the tools we can, but at least in the way it's traditionally has been used and its approved use, far shorter than these effects of psilocybin. And we see that the reductions in depression and anxiety are significantly related to how mystical the content was in the session. So you'll see that theme continuing. It's about the experience. Don't have got time to go into details, but it's not just us. Before us, there was at about half the dose, Charlie Grobe also showed reductions in with psilocybin in cancer patients with depression and anxiety. And then published at the same time of us, our colleagues at New York University with a slightly different design, but nonetheless also finding extremely large effects in the same range of hours, so extremely complementary, finding also these reductions in depression and anxiety. And then our colleagues at Imperial College finding in an open label, non-randomized study, reductions outside of cancer, reductions in people with major depressive disorder. And I'll share briefly that we have recently completed a randomized trial with psilocybin for major depressive disorder, which will be published soon. It's now accepted, and I'll just say that we have also seen large reductions in depression outside of cancer in the context of a randomized trial. So stay tuned for those data. I'll now switch to smoking cessation. There's previous research suggesting LSD could treat alcoholism, and a little bit of research suggesting heroin addiction. We thought there was this cross drug signal for anti-addiction efficacy, so we decided to try tobacco smoking. It's a great target for one reason, and that tobacco kills more people than any other drug. All of them combined doesn't come close to what tobacco does, so it's a legitimate target. It's easy to biologically verify abstinent, which is attractive to me. I'll say, hopefully you get the point in my discussion of risk that we're certainly not encouraging people to do this on their own, and this research has gotten some attention from the media, which we appreciate. So I'm not telling people they should do this on their own, but I really want to emphasize here, definitely don't do this. That's a heck of a lot of mushrooms. They didn't clear that photo with us. That's a lot of mushrooms. Like, not advising that for sure. The demographics of our pilot studies, basically, these were real deal smokers. I averaged smoking for 30 years and smoked about a pack a day. These were not lightweight. So we combined it. I'll go quickly, but we combined it with cognitive behavioral therapy over 8 weeks of treatment. There were 3 sessions. A few people had only 2 sessions. They opted out for the third because they didn't think they needed it. Their target quit date for smoking was on the first psilocybin session. This is carbon monoxide, a biological metric of recent smoking. This is before psilocybin. This is after psilocybin. You don't need to be a stats whiz to see you have a pre-post difference here. And in terms of percent abstinence and point prevalence abstinence at various time points, 80% of people were biologically confirmed as abstinent at 6 months. That held up on an average of 2.5 years at 60%. So I'll just say this is far and away larger than what's typically reported in the literature. In fact, to my knowledge, larger than anything that's ever been reported in the literature. Success was related to mystical experience. I see Eric
I hate
unmuting probably.
We have to wrap up, Matthew, in a few minutes, 2 minutes.
Wonderful. That's perfectly perfect. Related to mystical experience. We have some qualitative analysis. Don't have time to get into. I'll refer you to that. People had all kinds of interesting things say about self-identity and meaning related to these sessions. This is the new stuff. The current results. We're doing a randomized study with 80 people. Either nicotine patch versus psilocybin, just one psilocybin session. 44 people, it's been a year since their session. Remarkably, at this time, we are seeing 59% success, biologically verified abstinence in the psilocybin group compared to 27% in nicotine patch. It looks amazing. It could change. The study is still ongoing, but we're still extremely encouraged. Similar results for alcohol use disorder showed by Michael Bogenschutz, our colleague. We've done several studies in that naturalistic addiction recovery, where people take these things recreationally and then report recovery from not only alcohol and tobacco, but for cocaine, cannabis, opioid, methamphetamine use disorders. In terms of understanding psychedelic behavior change, I think the key, as Ben alluded to, is there's something transdiagnostic going on. I think of all of these disorders as addiction broadly defined. Even in the context of depression, it's addiction to thinking about yourself in a certain way. I think there's something special about the serotonin 2A receptor that this is pointing us towards in terms of the modulation of plasticity and meaning. I think essentially psychedelics work because they are psychotherapy. Again, a theme that Ben alluded to. Michael Pollan credited me with the dope slap effect. That's one way of thinking about this. These work as people are dope slapped out of their story. We have plenty to figure out to fill in the details of that. So that's it. Have a huge list of people to thank. No time to go through, but I'm probably forgotten some people because it's been such a group effort. Everything I've shown you and the incredible philanthropic support we've received. So if we have any time for questions, happy to entertain that.
Thank you very, very, very much, Matthew. We're all applauding again. It's a great presentation. And I see a couple of questions here. It feels like a real conference where I feel a little bit of time pressure and I wanted to cut you short and you're here and we need to give Michael the floor, but maybe a question that I see coming up in the Q&A, but also one that's driving me. We spoke about the transdiagnostic approach to mental health symptoms or so, but with Ben, I see a range of disorders in your presentation, but the one that sort of stands out maybe in other people that are asking these questions as well. Now, the mystical experiences, is it, and I'm going to ask it really bluntly or so, is it an epiphenomenon for the treatment of some mental health disorders, or is it a really an essential part of the cure?
I don't think it's essential. In part, if you look at our correlations in any of these studies, they're far from perfect. I mean, from my view, it's amazing that any aspect of subjective experience, after statistically controlling for how strong the drug felt, you know, which all of these results have showed you hold up to that standard, at least in our lab, that's amazing enough. But nonetheless, you know, so there's something about the subjective experience. Nonetheless, they're not perfect correlation. There are plenty of people who are helped who have not a complete mystical experience and very low. So something we've explored is the insightfulness level. Peter Hendricks has suggested awe as a construct, which we're collecting now, and it might be related, but somewhat divergent from mystical experience. And ultimately, I think that mystical experience is a crude construct. And I think it both psychologically and biologically is probably just a proxy for kind of like more valid underlying constructs we have yet to uncover. So we need to keep working on that.
Is there a personality trait or so, like somebody says here? What about if somebody departs from a high score on openness? Are these subjects more prone to mystical experiences? Did you look at that personality trait wise, whether some personality traits are setting somebody up for these experiences? So
something that's been found in the field so far is that the personality trait of absorption, as measured by the Telegon Absorption Scale, which is somewhat related to openness, has been, and we typically, people, as you can imagine, are already relatively high in openness. So these are things we occasionally go back to, and even if we see a little trend, there's not enough statistical power, so we can continue to address them as we accumulate more participants across studies. But Franz Wollenweider's lab has found that absorption is related to more propensity for more positive experiences, which I think makes a lot of sense.
Mm-hmm. So there are more questions if you have an opportunity to. Oh, you're going to be with us at the ICPR for another occasion, aren't you, Matthew?
Correct.
Right.
So I'm giving a talk tomorrow. Right.
Now, I wonder next time that I will see you, whether you will have a grown beard again or whether you've shaved it off or so. I grew a beard actually, and you took it off. So some corona effect or so are
right.
Well,
I'm in the States, so we need all the help we can get. So it
right.
It definitely does help with the mask working, not have a crazy beard.
All right. Well, it looks good on you, Matthew.
Thank you.
Thank you so much for your contribution. Are you going to stick around with us for a little bit after Michael or during Michael's talk?
Yeah, I'm able to stick around.
All right. Thanks. So
thank you.
Thanks again, Mike. Thanks again, Matthew. Michael, I was going to say, Michael Mithofer, who needs no introduction, and how wonderful it is for me. I wish that I would have sitting next to you on that chair left of you or so, Michael, but that's not here. We were Zooming a couple of days ago. It's wonderful to see you back again. And I just heard that there is a Michael Mithofer, what is it? A type of result. So maybe you can, Ben Sessa alluded to that. If you weren't there with us, there is a Mithofer type of result in his data sets or so. So maybe you can help us clarify what that's going to be, because you're the author of that effect.
Well, I missed that part of Ben's talk this time. I joined late, so it's a mystery to me, Eric. But
No,
as
it's a
far as
pleasure.
results go, I just want to comment, Matt, your results are always incredible, but just again, to hear that, I knew about your smoking cessation results, but the public health impact, potential public health impact of that work is just so huge. It's really exciting.
Hey, Michael, it's a pleasure to have you. It's also early morning because you're in North Carolina, is it? Or South Carolina? North
Carolina now.
North Carolina, right. So good morning to you. Glad you're here. And we may go off a little bit over time. I don't know if we're going to be thrown off by some people. We have until 3:15 on the schedule. So you have 20 or so minutes. If we're not knocked off, then we may go over a little bit, but not too much because the schedule is sort of very sacred here. Without further ado, Michael,
I'll do my best to move fast.
On MDMA psychotherapy for PTSD, because I would assume that that's going to be your topic. No?
Yeah.
Yeah. And Michael is the medical director of the MDMA assisted psychotherapy trials that have been started years ago. 2011 was his first paper. It's been almost 10 years ago, and there's the screen. So
okay, can you see? Can you see my slides now, Eric?
No, not anymore. We did see it, but now you're moving it into the screen.
Oh, okay. That's interesting. Okay, because I've got two screens here. So is my slide that says ICPR, is it in full screen?
Right. It says ICPR.
No, so we're seeing the PowerPoint, but not your PowerPoint presentation. So if you have it already on presenter view, you can share your other screen.
Okay.
Okay, I'm going to stop.
Just go to share slideshow. Yeah.
Let me try this one. What are you seeing now? Huh.
We don't see your slide deck, but we do see slides not in the presentation mode.
Okay, that's strange. I'm going to unplug my other monitor, maybe.
Okay. In the meantime, as Michael is preparing his stuff, I had the opportunity to meet Michael about 4 or 5 years ago after I met Rick, when we with the Dutch team went to New York. Where was it? Close to New York, where we were able to be part of the MDMA psychotherapy for PTSD training, and a lot of things have happened since. And we met on several occasions, Michael, which always has been a pleasure. And I'm just filling the time now here to make some
nice job, Eric. Okay.
But also to not make you more nervous, or actually decrease your nervousness.
I will try to share a screen again. Nice job filling the space. Let's see. Okay.
There. Oh, whoops. Now
you've got me back. All right. Now let's try this again. Okay. Screen share.
Now we're in business, Michael.
All right. Good. This is so strange. I've spent half my life doing this these days.
You're wonderful. We're all learning, and the learning curve is steep.
In the interest of time, I'm going to give you a whirlwind tour of where we've been, and a little bit of old and a little bit of new, as Matt said. So much thanks to MAPS and MAPS Public Benefit Corporation. It's like 3 or 4 times as big as this picture now. I can't keep up. It's growing so fast. So this work is all possible due to nonprofit donors and hard work from many people. So why are we doing this? We're studying PTSD, MDMA assisted psychotherapy for PTSD. And really the reason is because it's become obvious that pharmacology hasn't done so well with PTSD, that psychotherapy is really the first line and the definitive treatment, which is good to recognize. The problem is it doesn't work for many people. So maybe about half the people aren't served by the therapies we have. So, the idea is, what about a drug that could catalyze the psychotherapy? So these are drug-assisted therapy trials, not just drug trials, which makes them doubly interesting, kind of like Matt and Eric were talking about. Where's the pharmacological effect and what's the mystical or other effect? This is MDMA. It's been off patent for many, many years, and it's often referred to as a psychedelic. That's not a bad term if that means mind manifesting, but it's a bit different from classic psychedelics like psilocybin or LSD, in that it tends to be a little gentler and has this kind of heart opening quality of people feeling more close to others and to their inner experience. So it's an interesting compound to study. Midomethamphetamine is the generic name now that MAPS has registered. It's a complicated drug. Not going to spend a lot of time on this, but it's a big part of the effect is release of monoamines, especially serotonin, also binding to serotonin receptors. It also causes release of and increased levels of hormones, including oxytocin and prolactin, which are kind of interesting from a psychological standpoint. And as most of you probably know, before MDMA became illegal, there was considerable clinical experience with it between the late 70s and 1985 when it was put in Schedule I. And reputable psychiatrists and psychologists wrote reports about it, although there was no controlled research done at that time. And then, it was an example of politics impeding science, because that the reports suggested that, this should be pursued vigorously with controlled trials, which didn't happen for a long time, but now it has been happening for a number of these compounds. So just a review of some of the trials that we've done and we're doing at MAPS. This is kind of the basic design of our phase 3 trials that are going on now, but similar to the phase 2 trials. The main point I want to make is those 3 pink circles are the only times people receive MDMA. There are 3 MDMA assisted sessions a month apart, approximately, where people are randomized to either active dose of MDMA or inactive placebo, or in some studies, low dose MDMA. And then the other important point is those green bars are the preparatory sessions ahead of time, and then the integration sessions afterwards, which are very important. It has a big effect, as Matt was saying, the set and setting and the preparation and the support has a big effect on the experience. These are the 6 phase 2 trials that MAPS has completed. We did a couple of them in Charleston, and then there've been studies in Switzerland and Colorado and Israel. Those 4 have been published, so you can read the results. I'm not going to go into the details, but these are from 2 of the studies we did in Charleston. And for the first one, we had a very long follow-up of 42 months. And then these are the published studies from Switzerland and Boulder. And then last year, we published the pooled results of these 6 studies and showing pooled effect size of 0.8 after 2 sessions, 0.9 after 3 sessions. And this was comparing to all the same psychotherapy alone. So it wasn't just a placebo study. It was all that rather involved and lengthy psychotherapy sessions, which had an effect. This is the graph of those numbers. The top line is the placebo or low dose comparator control, and the other line is the active doses of MDMA, 75 to 125. This is the CAPS-4 scale that we used in phase 2. So very robust results. And we also, in the later studies, we started measuring some other things, and we saw indications of improvements, trend toward improvement on the back. In some studies, there was statistically significant improvement on the back, and also improvements in sleep and post-traumatic growth. And now we just published a long-term follow-up from those pooled long-term data from those 6 studies a year or more afterwards. And what we saw was in these people, all of whom had to fail prior treatment, with all that intensive therapy, 23% of people no longer met criteria for PTSD after 2 months later, after all the therapy without MDMA. But with the MDMA group, it was 56%. And interestingly, at 1 year, it was 68% no longer met criteria for PTSD. Not just improvement, but losing the diagnosis. So that's something we see typically. That's Matt's data kind of points to this too. People keep getting better over time. The process seems to keep unfolding for many people rather than the effect of the drug wearing off. MDMA has side effects, of course, like everything else, every other drug, increased blood pressure and pulse, especially. There are a number of minor self-limited side effects. Of course, it can be dangerous in the wrong setting or in the wrong person, so it's not trivial. There have been deaths in recreational settings, but no deaths or unexpected serious adverse events in research settings. So it has a good safety profile using pure MDMA in a controlled setting with carefully screened participants. These are the 6 most common side effects we see during the MDMA sessions. Those are the ones that are more common with the active doses than with low dose or placebo. So you can see they're nothing alarming, but they do have these things do reliably happen during the sessions. As far as the blood pressure elevations, they can be quite large. So just to give you a feel for it, those are the maximum doses, maximum levels within active placebo. You can see people's blood pressure and pulse went up quite a bit processing trauma without MDMA, but they were higher with MDMA. But we never had to treat anyone for elevated blood pressure. We do careful medical screening and psychological screening by outside screeners. That's important. And these are some of the inclusion-exclusion criteria. We include other psychiatric diagnoses, but not psychotic disorder or DID or bipolar type 1 or active substance abuse. And we don't include people with severe medical problems. We do, in a couple of the studies, the first 2 phase 2 studies, we did neuropsychological testing, R-bands being the most comprehensive one. We also did these other neuropsych tests, but I'll just show you the R-bands results, which were similar to the results for the other ones. So, there had been talk of maybe MDMA causes memory problems in recreational use, which is very hard to study in that population. So we did this prospective look at neuropsychological function, and we found on doses from 0 to 125 milligrams, we saw no evidence of change in memory problems or any other neuropsychological problems. So at the end of those 6 phase 2 trials, which we started, we got our permission for our first one in 2001, but it took a while to get started in 2004. And then as of 2016, those 6 studies had been completed, and we got FDA permission to move on to phase 3 trials and also got breakthrough therapy designation. So this is where we are now. We're just finishing the first of 2 phase 3 trials. We have 16 sites in North America and 2 in Israel that have just finished the treatment for the first study and starting the second one for phase 3. We got expanded access protocol approval in the US and Israel. Those haven't started yet, but we're hoping they will, and hoping to have that approval in Europe too before too long. There are phase 2 studies now are recruiting in Czech Republic and the Netherlands, and soon to start in other countries. And we have a phase 3 protocol that will follow those in various stages of review across Europe. So, and as I said, we finished treatment in the first phase 2 trial. We're working on the database now, and it should be unblinded in October. So that'll be good news. Mark it on your calendar, perhaps. October. We're not sure, but hopefully. Just a word about the fact that, about our thinking about what will happen if these phase 3 trials are successful and we get approval. There will be a risk evaluation and mitigation strategy. We don't know for sure what it will be, but what we think is, and what we think is a good idea, is it would only be administered in certified clinics by trained providers and would be shipped direct from the manufacturer to the clinic, so there wouldn't be a problem of diversion. This is our therapeutic approach, which I don't have time to talk much about, but you can, this manual is available free of charge on the MAPS website if you'd like to read the details, but it's based on a lot of what we learned from Stanislav Grof and others who did early work with psychedelics, and kind of combine that with our own experience with working with trauma. And this is where we do the sessions. It's a relatively non-directive or self-directed approach. We don't try to have an agenda about what the session what should happen in the session, but encourage people to be open to whatever comes. People spend part of the time reclining with headphones and music and eye shades if they're comfortable with that. And then that alternates with talking to the therapist, and we think both are important. And as I said there, we put a lot of importance on preparation and integration afterwards. And we talk about this idea that also sounds a little woo-woo, maybe, the concept of the inner healing intelligence, but I think it is a real thing that if you can create favorable conditions and have a catalyst to help people access their own inner healing intelligence, it turns out to be very helpful usually. And it reminds me a little bit of this quote from Irvin Yalom: "A therapist must strive to create a new therapy for each patient." I've always loved that. And I would say, and maybe taking it one step further, maybe the therapist must strive to allow and encourage each patient to create a new therapy for themselves. That's kind of our approach. And I made this slide a few years ago when we did a training in Windsor in the Netherlands. And I think our approach is a little bit like curling. You set something in motion, but then you don't mess with it too much after that. You maybe guide it a little and get some obstacles out of the way. That's how we do the therapy. And I've written a little bit, this was like 7 years ago now, but we've thought a lot about all the elements of other therapies that tend to come up when you take this non-directive approach using these kinds of compounds. So what we notice is all these elements that any therapist would recognize as part of psychotherapy, or most therapists would, even though what we're doing sounds so much different from most therapy, what we see is if we take this non-directive approach with MDMA, people tend to spontaneously have all these kinds of experiences, or at least many of them. You know, in a safe, supportive setting, people do imaginal exposure. They notice cognitive distortions. There's always, the transference can be heightened. There are always psychodynamic elements. Even if people come in with war trauma, they're going to talk about their childhood and their relationships. We pay attention to the body, so there's somatic elements, and people become more aware of normal multiplicity of the psyche. We see transpersonal mystical experiences, not only about a third of the time with MDMA as opposed to psilocybin. And they don't correlate, in our studies, that hasn't correlated with outcomes, so it's an interesting difference. And people often have strong corrective attachment experiences with the MDMA seems to foster. So I think all of that, and there's often powerful imagery. So I think all of that can come into play. And if you stay out of the way and don't focus, you know, push people in one direction or the other, they're apt to have a really interesting combination of these kinds of experiences that are going to be different for everybody and come up in different orders and to different degrees. So it's an encouragement not to lose the sight of the forest for the trees, and not to reductionist thinking. I think is something we should be aware of, because if we really look at what's happening with these compounds, it's very impressively broad and complex and rich, I would say. So why does this MDMA help people to process trauma? I'm not going to talk much about that. We're mainly studying whether it does or not and whether it's safe. But I just want to say a few words. There's a lot of interesting work that many people are doing in this area. Stuff about, promoting fear extinction in animals, ideas about memory reconsolidation, increased neuroplasticity, opening socially dependent reward channels. All of this is really exciting new information coming in. But I'm going to focus on one thing that correlates so well with what we see clinically. And it's a bit simplistic, but I think it's part of the picture. So we know people with PTSD have increased activity in amygdala and decreased activity in prefrontal cortex and hippocampus. And we know that when you take MDMA, activity in prefrontal cortex increases and activity in amygdala goes down. And that would fit with kind of this idea. This is kind of what we see clinically. This is an idea from many others have written about. This is adapted from one of Pat Ogden's books. But this observation that therapeutic change happens within an optimal arousal zone or window of tolerance. And if the people are trying to revisit trauma in therapy and they're hyper-aroused and overwhelmed by anxiety, it's not helpful. Conversely, if they're emotionally numb and talking about the trauma but not connected emotionally, it's not helpful. And of course, people with PTSD often go to both of those extremes. So the idea is if you can have some time in this optimal arousal zone where you're alert, engaged, but not overwhelmed with anxiety, that's when change can happen. And that's very consistent with what we observe. And there's some other interesting work. This is from Robin Carr-Harris's lab in Imperial College London, and others are studying these kinds of things too. But changes in the relationship of the networks in the brain and decrease in resting state functional connectivity between prefrontal cortex and hippocampus, and increase in between hippocampus and amygdala happens with MDMA. This is one of Robin's papers. It's not about MDMA, but it's about 5-HT2 drugs, of which MDMA is one. And this idea that what's happening when you see those changes is this idea that Robin calls relaxed beliefs under psychedelics. The idea that they create this more entropic state in which suddenly all these fixed beliefs that have been keeping people pinned down from the cortex are relaxed and people can consider new information. Or as Mendel Kalin in Robin's lab has said, it's like, it's as if when you have PTSD or maybe when you're a human being in a lot of situations, it's like sledding down a hill. After you've gone down a few times, you can't turn out of the same track. Whereas you take one of these compounds and it's like new fallen snow, suddenly you have a chance to respond differently. And that's very consistent with what we see. So do I have time for a few quotes, Eric, or how am I doing?
Well, I was looking at the questions that are coming in, and do you want to take a question or so, one or two?
Sure, whatever you think is most useful.
We do need to take a break. Some people need to go to their bathrooms or want to have switch of chairs or whatever, and then we need to be back at 3:30. So, do you want to share some quotes, and then I'll end with one question?
Okay, sure. So these, just to give you a feel, these are things people have said. This is an important one. Several people said, I don't know why they call this ecstasy. So it's making the point that it's not just that people get blissed out and everything's fine. Processing trauma is painful with or without MDMA. It just may be possible with MDMA. And this is a good one. Maybe one of the things the drug does is let your mind relax and get out of the way because the mind is so protective about the injury. Many people said that kind of thing, which fits with the amygdala being settled down. And this, a lot of people said it changed their relationships, their emotions. I have respect for my emotions now. What's most comforting is knowing now that I can handle difficult feelings without being overwhelmed. And people felt they could do it with the MDMA. They realized I can probably do it without the MDMA, and they found they could. well, I want to just go to this one. I'll make this the last one. This is one of the veterans that said, as interesting as the sessions are, I know from experience now that it's even more interesting what happens after the sessions when you're making connections. I think that's a really important point. It's not just what happens in the MDMA session. It catalyzes this process that really does keep unfolding. And that would fit with the fact that we see on average, people have lower PTSD scores a year later than they did 2 months later. So I'll stop my screen share.
Thank you, Michael, for that walkthrough in a flurry of data. And you've presented this hundreds of times. And when I see it again, the first time that when I saw it, I was blown away. As sort of the Mithofer effect or so that Ben said, you were the first one to show dramatically that we quote unquote can cure patients with chronic and complex PTSD cases. So it was either too good to be true or not true, but we followed you over the years and it is true, Michael. So
yeah, thank God. Many other people have demonstrated powerful effect now, so we can get over that one.
One question here that somebody asked is, did you included in some studies personality disorders? Did you find any significant correlation between personality disorders and lack of response? Could you briefly say something about that?
Yeah, we don't have enough numbers to really say much because we started out where we included the only personality disorder we screened out was borderline personality disorder in the first few studies. And we did have some people with a lot of traits of that. And we couldn't clearly see that they didn't do as well, although our impression was they probably would have done better with more flexibility over a long period of time. So our impression was it could be helpful, but it may take more sessions, or not even necessarily more MDMA sessions, but a better container for more support could be good. Then we started, in the later phase 2, we started screening out personality disorders. So we don't know. That's going to be important to look at because I don't in any way get the impression that it's not a good idea. These kinds of things couldn't be good treatments for personality disorder. I think they probably could be done in the right way, which might need adjustment, of course, according to the situation. What we do is have some pilot data showing that when in our lead-in to phase 3, the open label lead-in, another small study, but we measured number of adverse childhood experiences. And in this very small data set, we found there was no correlation between adverse childhood experience and outcome. People with more adverse childhood experiences did as well as people with fewer, and that held true for males and females. Again, interesting pilot data. We'll learn more soon when we get information from phase 3.
Now, I was challenged to ask you to say a little bit more about the in-between sessions, the integrative session. But we may revisit that, as well as the training method that Matt has unfolded, in which a personal experience with MDMA is part of the training. And I think in the next session we may come back to that, and so you could comment on that as well. Why you feel, as others in the panel later, are important training opportunities that probably enhance your quote unquote ability or joy or experience in being a therapist, specifically for this protocol. I want to leave it because we got six minutes, Michael, and you're going to be with us after this panel. So you just rotate your chair or take a couple of breaths, or we do some other exercises. And I think the moderator or the chair will take over for a few seconds. We go offline or so, and then in 6 minutes we'll be back alive for the second part. Thank you so much, Michael, for this wonderful opportunity to have you present.
Thank you, Eric. Really enjoyed it. See you in 6 minutes.
Yes.